Thank you so much for inviting us to see to talk about this paper. And I have to say, it was a work that it was amazing. The people that I work with, there were a lot of people involved in this paper. And on behalf of those persons, I would like to tell you, thank you very much for inviting us here, for being here to listen to our work, and for the award, of course. So let's start with the paper, which was published just a few months ago in the New England Journal of Medicine. And because you all are experts in oligonucleotides, I will try to talk a little bit more about the disease, which may be a little unknown for most of you because it's a very rare disease. It was just recently in fashion, I would say, because this disease turns out to be very interesting in many points of view, including the therapeutics that are being developed for the disease. So it's called hereditary Transthyretin-mediated amyloidosis, or TTR amyloidosis, as we call it. And it is a rare inherited disease which it's been inherited by autosomic dominant mode. It's debilitating, life-threatening, and it's often fatal. The symptoms start at least in between 30 to 40 years old in average, and the patients will survive around 3 to almost 8 years afterwards with a debilitating progressing neuropathy, and also with cardiomyopathy and gastrointestinal diarrhea, constipation that would lead them to a a lot of loss of the body mass index, and they will die. This presentation includes sensory, motor, and autonomic symptoms, and the disease continues to spread in these family members, and they often get the symptoms in younger generations, which is called anticipation. And Patisiran is the nanomolecule formulation that is administered by IV infusion, and it targets the hepatic production of this mutant or wild TTR. It's approved in the US, and it was recently also approved in the European community. So the study, this is the design of the study. The patients either receive Patisiran, 2 of them, per one that received placebo. The Patisiran was received every 3 weeks, IV. And what we tried to, the first endpoint was the change in the neuropathy that was evaluated by this NIS scale, which I talk a little bit more in the upcoming presentation, but what I want to say, it's mostly the motor impairment, followed by the sensory impairment, and afterwards the reflexes, and also it has some autonomic features, particularly the blood pressure fall in the autonomic component. And then we had other secondary endpoints, which were the Norfolk, which maybe you know, which is a quality of life scale, the RODS, which is an activity of daily living, the walking test, and the BMI, which I told you about. They lose a lot of weight, so we measure the weight, but it's modified because we also try to compose with the albumin loss of the GI symptoms for the diarrhea. And mostly also the autonomic features evaluated by the COMPASS 31 scale. And of course, other selected exploratory endpoints, and here I have to say, mostly were done with the cardiac assessments. It was not the primary endpoint. The endpoint was neuropathy, but because this is a mixed disease, we also had some secondary cardiac endpoints. So this is the NIS, what I was talking to you about. It's a lot of the motor strength. Remember, these patients, they go into wheelchair very early on the disease, and that's how they die, either in the wheelchair or bedridden. They cannot walk. And then we have the QST, which also goes into the small fiber. It assesses how the patients are feeling and how they lose this sensation, and reflexes, nerve conduction velocities, and at the end, the autonomic with the postural blood pressure. The clinical manifestations, they go through stages, and it starts mostly with the motor, and then it becomes very evident the autonomic and the heart, and those were the assessments that we have. We have to say that this was a very multinational study. It was 44 sites in 19 countries, Most of them fell either for Europe or North America, and most of North America, I don't know why they put Mexico as the rest of the world, but it's also North America. I always get angry about it. We have all these countries participating. As I said before, we had a randomization 1-to-2, and you can see here that there were 77 patients with placebo versus 148 patients with Patisiran. And the dropouts were mostly the same thing. But there's something interesting that you have to be here to see here. The progression of the disease was the motive of dropout in the patients with placebo against one which had treatment. So patients really felt sick when they were in placebo. This is our demographics of the study. As I said, it's male to female 1-1 because it's an autosomic dominant disease. So we have most of the patients balanced, but they were a little bit more male than female in the study. Not that much, but they were more male. There were all races involved, and they were all geographic regions. The median time from the onset of the symptoms to diagnosis was around 1.3 years, and half of the patients have had stabilizers before, other kind of treatment. And then we have, you know, there are more than 100 mutations that can cause this disease. So we had one, which is the most common one worldwide, which is valin 30-met, where 40 to 56 patients per group, and then we have all other these mutations that are not well characterized because they are very rare. They were half of the rest of the patients. We, as I said, had these FAP stages, which was one that they can walk without any aids, two that they need some cane or some crutches to walk, and three that they are wheelbound. And we had more into the 1 and 2 phase, but there was one also in 3 phase. And then, as I said, it was not the endpoint, the primary endpoint, but we were also staging the patients for the New York Heart Association cardiac disease. So we had 1 to New York Heart Association disease staging in these patients. And then you can see here the dramatic drop of serum TTR since the first dose of the medication. And the also good thing about this slide that you can see is that it persisted all over the study. So this difference in the reduction of TTR is what we hypothesize that it will make the disease at least not to be more progressive in 18 months. But surprisingly, it didn't only progress, as you see the patients in placebo in this slide, but it decreased. The patients improved. And this was really surprising. We cannot understand why. I mean, the deposition of the amyloid got a little bit cleaned from the organs, and the patients start feeling better, but it was consistent in the motor, sensory, autonomic evaluations that we made that I told you that we were evaluated by this modified NIS+7. Also, and very interesting, the patient had a difference, a very important difference in the quality of life according all the different sets that we study. And both the modified NIS+7 or the quality of life were consistent in subgroups including age, gender, race, region where the patients were, NIS when the degree of severity of the disease when they were in the study, the genotype, and the use or not use of previous stabilizer. This is just the column, the graph, so you can see the great improvement that they had in comparison with Patisiran, with placebo. And you can see also that this was consistent with the secondary endpoints that I told you about assessing disability, assessing walking, assessing the body mass index, the modified body mass index, and assessing the autonomic components of the Compass 31 scale. Safety and tolerability was really good. The patients had most of the adverse events that were really associated with the disease, with constipation, diarrhea, edema, things that we see in the natural history, and they were not different in the patients that had placebo or the patients that had patisiran. There were a few infusion-related reactions, which are very well category for saying something happened while the patient were receiving the treatment at that exact point. That will include maybe some flushing or sometimes a little bit of pain or another discomfort during the infusion. There were 13 deaths. No of those deaths were considered related to the drug. There was similarly a frequency of deaths between the patients that had the placebo or the ones that received patisiran, and there were no safety signals, meaning there were no thrombocytopenia, there were not related reactions with the renal impairment or another secondary reaction for the drug. As I told you before, this was not a study that was aimed to have the cardiology endpoint. However, it was very impressive too that we saw some differences, very important difference in the cardiac measurements, such as the ventricular wall thickness was a little less thick in the patients that received patisiran, and also the pro-BNP, which is a marker, a serological marker that we use for categorizing the cardiac insufficiency in these patients, was also lower. It was lower in the patients with patisiran. So in conclusion, this Apollo study was a multinational study performed to assess the natural history while receiving patisiran or placebo, and we show that it has benefits in the motor, sensory, autonomic impairment of patients, which was this first endpoint, and then in all the secondary and exploratory endpoints that were developed in the beginning of the study. There was reductions, disease symptom and disability, and there was also improvement, very, very, very great improvement in the quality of life. So patients felt this, despite they did not know what they were receiving, they were feeling better while they were on the study. It was also an important issue that they had the improvement in nutritional status and in the cardiology manifestations of the disease. There were no secondary events for the drug. It was safe, and all the patients were eligible to go into the open phase extension of the study. Which gets me to what you all know, you're experts on this, how we went from the benchmark from a scientific report in these flowers in petunias that didn't go violet, they were white, but they were using these kind of molecules, up to having a Nobel Prize, to having it available for the patients. So I want to thank you all.
That excellent talk. I think we have time for a couple of questions. I'll ask one. You know, it's so exciting for us who've worked in oligonucleotide therapeutics to see drugs come out and to actually be used in patients. But in the US and in many countries, there's a lot of concern about the cost of medications. And I'm just wondering, in Mexico, you know, are there barriers for patients in Mexico to get a new therapeutic like this, or will it become rapidly available to your patients?
No, let me just starting to say that the disease is not even recognized in the Mexican authorities. We are trying to do that. But I think that the first important thing is this drug is IV. It's every 3 months, and it's quite expensive. It's just the beginning of what we're seeing. Yeah. And it will be developed easier into getting to the patients and also easier into the costs. And that's what we aim for.
Yeah, yeah, it'll take time. Thanks.
Yeah, this is Nori from Tokyo Medical Dental University. So we really appreciate your great success in the first sRNA and drug, especially in Japan. This FAP patients, so many. So my question is that you show that the VMAT30 is the most common mutations of this hereditary disease. Did you find any difference between VMAT30 patient and non-VMAT30 patients in effectiveness of this patisiran?
Thank you very much for your question. I have to say the whole patients that I have, they are not Val30 met, I do not have, well, I only have one, but it was transplanted from Venezuela because what's happening to Mexico. The rest are all non-bat male, and they did very well. However, in the whole study, when they analyzed the whole study as a group, there were no difference between VAL30 and non-VAL30, or either initiation early versus late onset of the disease.
Yep. Okay. Gene?
Hello. Thank you. Excellent talk. I'm just curious from a clinical perspective what the regulatory agency perspective was on the use of placebo groups in these kinds of severe patients.
The placebo is always challenging for everybody, including the PIs that we are treating patients. However, there was this, they accorded that if the patient was with previous RNAi, particularly, well, with previous treatments, particularly the stabilizers of the disease like tafamidis, they were not, they did not have to leave the treatment before. And because I come from a country where there are no options, we didn't have really that ethics problem, but there are some countries, particularly in Europe, where other treatments are available. So what they also stated is these guidelines, like for example, if the patient is doing well with this treatment, they won't go to a trial that might have placebo. Only those patients that would have like progression despite being in a treatment, they might consider going into a different medication with the knowledge that they will have placebo, or they have the chance of having placebo.
Can I just quickly follow up? Were the clinicians aligned pretty much on the use of the placebo group with the regulatory agency, or were there back and forth and discrepancies?
It was a struggle. However, this design was done more than 8 years ago. Tafamidis was only in the beginning and showing some results, but this was like designing the study without really actually having in the market available everywhere a stabilizer. So I think that made it easier, at least that for now that there are some treatments developing, that will be more challenging to have the just placebo versus the active drug.